Okay, guys, moving into ARDS, acute respiratory distress syndrome. Some of the causes is a direct injury to the actual lung. This could be bruising of the actual lung tissue. This could be penetration of the lung tissue, any kind of blunt force injury or penetrating injury to the lung. Specifically, also chest trauma, right? We can hit our chest so hard that we snap a lung or we crack a rib, and it could possibly penetrate our lungs as well. Any kind of aspiration from emesis, remember that we can cause this with our drug overdoses. Any kind of smoke, chemical, or saltwater trauma, infections for sure, sepsis for sure, pancreatitis, we'll talk about in a little bit, and any kind of form of drug abuse can lead to ARDS as well. Okay, so ARDS technically has three different phases. The exudative phase, which is that fluid buildup in the actual lungs itself. Because the fluid is building up, the fluid does contain some acidity to it, so it actually kind of starts breaking down the protein structures or denaturalize the protein structures of the cellular wall. So the proteins and the macrophages will actually build up in the actual alveoli sacs themselves. Phase 2, that connective tissue and all the structural cells become dense because they're actually engorged with fluid. And then the last phase, the actual last phase is going into respiratory failure because we're not able to utilize the oxygen for energy. Our ventilatory rate's going to start going up. We're actually kind of starting to drown in our own fluid at that point. We're going to start developing hypoxemia because we don't have enough of the actual respiration to occur, so our red blood cells are not being saturated with oxygen the way they're supposed to. And then this is going to go into multi-organ failure throughout the body, leading to death. Okay, so in a nutshell, just to kind of make up what I just said, a little bit easier to understand. The alveoli, because of the fluid, actually become semi-permeable, so we're not able to conduct the diffusion that we're supposed to be doing between the oxygen and CO2. Because of this, the actual capillaries themselves become engorged, and they start kind of releasing their third space and more fluid from the actual capillaries. Because of this, the actual lung tissue itself is kind of starting to become dehydrated, so it starts washing out that surfactant. That's when we're going to actually start hearing those pleural rubs in our lung sounds. We're going to completely damage the alveoli. Okay, we're going to damage the actual expansion and contraction of our alveoli in order for actual gas exchange, and eventually those are going to collapse and die off, where gas exchange is not going to be able to occur ever again in that section of the lung. Classic signs and symptoms: extreme dyspnea, really feeling air hungry, which can definitely lead to some kind of altermentation, specifically going into like a hypoxic rage. You guys are going to hear adventitious lung sounds. We're going to get really low end-tidal CO2 readings, and I'm sorry, we can get really weird end-tidal CO2 readings. They could be high or low. We're going to have hypoxemia, so we're going to have naturally low SpO2 readings, and these symptoms happen pretty quick, usually within 24 to 48 hours of the initial injury to the lung. Risk factors for this: smokers, anybody that has any kind of chronic lung disease or some kind of chronic respiratory disorder. Our geriatric patients, usually anybody over 65, are a little bit more prone to this as well. It really does kind of increase the actual mortality rate anywhere between 30 to 40%. Really, the best treatment for ARDS is really kind of trying to focus on whatever the underlying cause is, or focusing on the disease process that the actual patient has that may have caused the actual ARDS in the first place. And CPAP goes a long way with these people, guys. We need to make sure that we start them on CPAP early, give them that therapeutic communication, explain to them the actual procedure, making sure that there's no actual contraindications for the CPAP itself when we're actually starting this procedure, and just kind of monitoring your patient, specifically heart rhythms and end tidal CO2 and SpO2 along with the patient's mentation.